All right. Good afternoon, good evening, everyone. Thank you for joining us tonight. This is our 7th pediatric webinar series, and Dr. Kaitlyn Strumph is going to be our presenter tonight. Kaitlyn Strumph is a pediatric hematologist-oncologist and assistant professor of pediatrics at the Children's Hospital at Montefiore, CHAM. She completed her fellowship at CHAM, during which she obtained a master's of clinical research through the Albert Einstein College of Medicine. Her research has focused on understanding the causes of silent infarcts and neurocognitive deficits in children with SCD. She also leads a monthly collaborative conference that reviews brain imaging and develops treatment plans for children with SCD affected by cerebrovascular disease. Dr. Strumph?
Thanks, Michael. All right, so today I'm going to be talking about sickle cell disease in the brain and kind of understanding how it relates to school difficulties and mental health challenges. I gave a somewhat similar talk last year at the academic Gen Peds Grand Round, so this may be somewhat familiar to some of you, but I did update a little bit of it, so hopefully there's some new things in there. All right, I have no conflicts. Okay. So just for the outline, so first I'm going to review the types of CNS complications in sickle cell disease, and then we'll discuss the modifiable risk factors and downstream effects of CNS injury, including neurocognitive deficits. We'll explore the associated outcomes of neurocog deficits in sickle cell, and then discuss some of the mental health associations that we've seen. And at the end, I'll review the American Society of Hematology's CNS disease guidelines that are related to cognitive deficits in sickle cell. And then at the end, I'll briefly examine some available interventions that hopefully everybody can take part in. Okay, so sickle cell is the most common inherited red blood cell disorder in the United States, and it affects at minimum about 100,000 individuals in the United States. And as a result of a beta globin gene mutation, complications arise due to chronic anemia, hemolysis, and intermittent vascular occlusion, which causes tissue ischemia and end organ damage. So as a result of this disease really has multi-system effects. And I think of those effects, ischemic cerebral injury is really one of the most devastating outcomes of this disease. So included in that ischemic cerebral injury, it's important to understand the difference between both strokes and silent cerebral infarcts, which are two things that we see in sickle cell. So I'll clarify the difference before I go on, but infarct is based on a neurologic exam. So strokes are an acute neurologic injury as a result of ischemia or hemorrhage in the brain. And these patients will have to have a focal deficit on exam. Compared to a silent cerebral infarct, or a silent cerebral infarct, or an SCI, sorry, on the other hand, is when you see lesions on imaging that are consistent with a brain infarct, but they're not paired with overt neurologic damage or deficit. It doesn't mean that they don't have other downstream effects, but just by definition, they cannot be associated with focal neurologic deficits. So this is technically the definition of what a silent cerebral infarct is, and it's a discrete infarct-like T2 hyperintense lesion that measures at least 3 millimeters in diameter, and it's seen on 2 orthogonal imaging sequences. The really big take home from this is that you should just know there's really a lot of challenges in the definition of these silent cerebral infarcts. I'm not going to really get into that too much, but just know that challenges do exist. And a lot of it's really just based on, over time, our imaging gets a lot better, and now we're able to, I think, appreciate more of these infarcts compared to, even the past 10, 20 years. So just so everyone has an idea of the prevalence of these events, so ischemic strokes prior to the initiation of hydroxyurea and transcranial Doppler screening, ischemic strokes occurred in up to 11% of children with sickle cell anemia, which is obviously very high. And in the post-screening hydroxyurea era, that number has come down to a cumulative risk of about 1.9% by the age of 18. Obviously, we've made marked improvements in the rate of ischemic strokes, but I still personally think that 1.9% is really high. And the prevalence of silent cerebral infarcts is even higher. So by the age of 11.9% of children with sickle cell anemia will have a silent cerebral infarct. By the age of 18, it goes up to 39%. And by the age of 30, over half of people with sickle cell disease will have a silent cerebral infarct. I just like this figure. It really just shows those numbers, and it just demonstrates just how high the prevalence is in our pediatric population. And, we know that this trend is linear and it does not level off in adulthood. So in general, I still think we have a lot to learn, both about, the risk factors that go into the CNS injury and the conglomerates of, outcomes that happen as a result of them. There's really just these big black boxes, I think, but we are learning a lot more. So first I'll talk about just some of the risk factors, and then we'll talk about the outcomes, which is the bulk of the talk. Okay, so this is one of my favorite diagrams. It really shows the multiple factors that likely play a role in ischemic injury. And I think it summarizes fairly well a lot of the evidence we've accumulated surrounding what causes these events. So you can see, on the left, there's relative and acute anemia. So if a patient comes in and has an acute drop in their hemoglobin, whether it's from an acute crisis or a parvovirus infection, that can cause ischemic injury. If you just have a low baseline hemoglobin, so just low, baseline more severe anemia, those kids are at higher risk for having ischemic injury. Up top, you can see patients who have higher hemoglobin S percentages also have higher risk of ischemic cerebral injury. When we talk a little bit later about hydroxyurea, that's something that can modify that hemoglobin S level, which can potentially help decrease ischemic injury. On the bottom, so when you have drops in oxygen, that can lead to ischemic injury. So things like acute chest syndrome, patients who have fevers and have increased oxygen demand, right? That can also lead to ischemic injury. And then on the right, we have CNS vasculopathy. So things like moya and stenosis that we see in our patients with sickle cell. And then up top on the right is the conventional risk factors that we think of in the general population that can lead to ischemic events. So this is where we as pediatric hematologists, I think often do not focus enough, but I think for all the primary care physicians listening, I do think you're probably much more instrumental in helping picking these things up. So in particular, I'm just going to talk about hypertension for a second. So children with sickle cell often have relatively lower blood pressures compared to age-matched norms. And on top of that, if you look at 24-hour ambulatory hypertension, which is when patients get a blood pressure cuff that they wear for 24 hours, and they look to see if they have hypertension both over the 24 hours and also it looks at it overnight. What they've seen is that 35 to 44% of children with sickle cell do have ambulatory hypertension. Of those patients, 34% of them have what's called masked hypertension, meaning that if you were to see the patient in clinic, they have a normal blood pressure, but they actually, if you look at it over 24 hours, do have hypertension. And then of those patients, again, who have ambulatory hypertension, about 59% have abnormal overnight blood pressure. So it does seem like overnight blood pressures really can contribute to the physiology in sickle cell. So this is looking at the association of those blood pressure measurements that I was just talking about with cerebrovascular injury. In particular, if you just look here, so this is looking at nocturnal hypertension and masked hypertension. And you can see the nocturnal hypertension, patients who had nocturnal hypertension had higher odds of having a stroke or a silent cerebral infarct when we looked at imaging over the year, within a year from the ambulatory blood pressure monitoring. And the same thing for masked hypertension. So again, these are patients that did not have abnormal blood pressures in clinic, but they did have hypertension on the 24-hour blood pressure monitoring. And those patients, again, had a higher association with having a higher odds of a stroke or silent infarct. But clinic hypertension is still important. So this figure is looking at data from the SIT trial, which was a multi-center randomized control trial that looked at whether or not blood transfusions can decrease the incidence and progression of silent infarcts. And when they looked at the different risk factors for silent infarcts in the children in the study, you can see here, this is a combination of having relatively lower hemoglobin levels and higher systolic blood pressures. And in combination, you can see that you have a higher odds of having a silent infarct if you have higher blood pressures or anemia. So moving on, not all silent infarcts can be prevented. And I think, now we're going to talk about, really what are the downstream effects and how can we address them. So I know I first talked about just a little bit of the risk factors, but we're going to move on to the outcomes of CNS injury now. So what are some of the downstream effects of silent infarct? So we know that silent cerebral infarcts have it's associated with a significant neurocognitive burden in children with sickle cell anemia. A lot of this work is done in St. Louis. A lot of the published studies have come out of there, and a lot of things they've shown is that patients have a decrease in 5 IQ points. Most of the silent infarcts occur in the border zone regions, including the frontal lobe, and we know that the frontal lobe is important for executive functioning, and they've shown that patients who have silent infarcts have decrease in executive functioning. Silent infarcts are also associated with further neurologic damage, so patients that already have silent infarcts are associated with an increased risk of having an overt stroke further down the line. So this figure shows data from the cooperative study of sickle cell disease, which was another prospective cohort study that was started in 1977. And that determined really kind of the natural history of sickle cell disease, or one of the first, prospective cohorts. And this figure here shows the difference in verbal IQ between school-age children with sickle cell disease who did and did not have silent infarcts. And you can clearly see that for each group, on the x-axis, the verbal IQ is significantly lower in the group with silent infarcts. This was a more recent study that was done in 2014, and it was a meta-analysis looking at all the studies or majority of studies in children with sickle cell disease who had full-scale IQs and the presence of silent infarcts that were reported. And it included 10 publications, and on the right you can see the results of the fixed and random effect models, showing that the mean difference in full-scale IQ between children with sickle cell disease with and without silent infarcts. And you can clearly see the 5-point difference in IQ that was seen when analyzing the 10 studies. So this was the data that I was talking about that shows the decrease in 5 IQ points in patients who have silent infarcts. So here was a study, or this was a table from a study that does a nice job of localizing the specific type of cognitive difficulties we see in children with silent infarcts. And this is, more than just like the full scale IQ. So this was using neuropsych testing, and they evaluated children with and without silent infarcts, and they also looked at their siblings. So you can see here that for language, the percent of children with deficits was much higher than that of a healthy sibling, right? So on the right, the healthy sibling, only 6%. But however, there was really no difference seen between children with and without an infarct. Same thing for visual, spatial, visual, motor, really no difference between the children with infarcts and without infarcts. Same thing with memory. However, once you get to attention and executive functioning, which I had talked about a little bit earlier, this is where we really see the big discrepancy. So you can see that 53% of children with sickle cell that had a silent infarct had attention or executive functioning deficits, compared to only 13% of children with sickle cell and no infarcts. And again, if you look at those numbers and look to the right, the sibling 0%. So there's really, sickle cell disease itself is likely associated with executive functioning, but if you're looking at the children who actually have signs of ischemic injury that you can actually see on imaging, those patients are at even higher risk of having executive functioning difficulties. So this was a study that was a prospective or a cross-sectional study that looked at patients ages 4 to 18 years old with sickle cell. And these are patients that had already been referred for neuropsych testing. So of those patients who had been referred for neuropsych testing for whatever the hematologist or pediatrician had thought was necessary, of those patients, 1 in 4 children referred for testing have ADHD. So obviously very high. Here is a study that kind of makes you think about how, right, it's not just sickle cell related factors, and it's also other factors such as sociodemographic environmental factors. So here this is looking at parental education in addition to whether or not the patient had a silent infarct or not. And what's interesting, you can see, is that patients with a silent infarct do have a lower IQ compared to patients who do not have a silent infarct, which we already know. However, parent education actually impacts IQ more than silent cerebral infarcts. And you can see up top, right, these are parents that had some college or more, compared to the bottom 2 lines was parents who had only graduated high school or less. Okay, so moving on to sickle cell disease and developmental delays. So what do we know about sickle cell in early development? So developmental delays are seen during the first year of life, and greater than 50% of children scored significantly below average on cognitive and expressive language subskills. So this is something that we actually can pick up pretty early. In preschool age, 25 to 50% have been shown to have developmental delays. And then further looking at preschoolers, we know that they do have developmental delays. However, they found that sociodemographic factors were stronger drivers of neurocognitive performance than disease severity. So again, I think the sickle cell disease itself is definitely a predictor of whether or not a patient's going to have neurocognitive deficits, but it's really looking at the whole picture and the other factors that can be at play. All right, so what about school performance? So this is looking at the proportion of students with sickle cell anemia with and without silent infarcts, and then looking at their sibling controls. And they were looking at whether or not the patients had either failed a grade or received special services. Okay, so you can see up top, siblings without sickle cell disease, 6% of patients, 6% of siblings had either failed a grade or received special services. And then sickle cell kids without a silent infarct, 27% had either failed a grade or received special services. And in this cohort, out of the 19 patients, 58% of the kids who had a silent infarct either failed a grade or received special services. So very, very high. This study also came out of St. Louis and evaluated school performance in 39 high-risk students. And high-risk students were considered kids who had had a stroke or kids who had been admitted to the hospital more than 3 times in the past year. And the age range that they looked at was 14 to 18, so mainly just looking at high school. And what you can see here is that they found that 28% had repeated a grade, only 33% were on target to graduate, and on average, they missed 38.4 days of school. So, this is this considerable amount of time lost. And of those patients, only 70% of patients with a stroke had been evaluated for an IEP. And only 13% had been evaluated for an IEP in the frequent pain or the frequent admissions group. So I think there's definitely room for improvement. And then what happens to these kids in adulthood, right? So this is the effect of silent infarcts on, or not so much silent infarcts, sorry, neurocognitive functioning on transition. So this figure shows how neurocognitive performance affects retention in adult care. So if you can see on the y-axis, that's the continuous Connors performance test. And on this test, lower scores indicate better performance, okay? So you can see here that retention on the left side, this is looking at retention in adult care greater than 12 months. And the right is looking at greater than 24 months. And the green indicates a favorable outcome. So you can see that patients who have worse cognitive scores, so higher numbers, had lower rates of retention into adult care. We already know that patients who do retain or do transition appropriately have better medical outcomes. So it is important that they're not transitioning. How about cognitive deficits and medication compliance? So this evaluated patients who had reported their own neurocognitive symptoms, and they associated that with hydroxyurea adherence. And patients who reported some level of executive dysfunction had a higher odds of non-adherence with their hydroxyurea. And then this is looking at adult full-scale IQ compared to norms, and you can see that essentially the bell curve is shifted to the left. So lower full-scale IQ in adults. Same thing that we saw in children, so as to be expected. This is also looking at the effect of full-scale IQ and other neurocognitive deficits, looking at the effects on employment. So at the top right, you see this is full-scale IQ. So in patients who were unemployed, they had a lower full-scale IQ compared to patients who were employed. This is just looking at people who have sickle cell disease. So, these neurocognitive deficits really have real-world consequences, right? All right, so now I kind of talked a little bit about what the downsides, obviously, to having neurocognitive deficits are, but just going to touch a little bit more on what other etiology of neurocognitive issues there may be in our patients besides cerebral infarcts. So this is just looking at other disease factors, actually. So the first study at the top was looking at the association of cytokine levels, because we know there's a lot of inflammation in sickle cell disease, and looking at executive functioning. And they did find that there was significant negative correlation between cytokine levels and executive function scores. Not surprising. And also this other study looked at transcranial Doppler measurements and hemoglobin and neural development. And what they saw was that TCD velocity was negatively correlated with development. So we know that higher TCD velocities are associated with increased risk for having a stroke, which makes sense, right? So if you have a higher TCD velocity, you likely have a higher risk for ischemic injury, and that would be negatively correlated with development. And then hemoglobin levels, as I talked about before, the better your hemoglobin, probably the less ischemic injury you have. And here we saw in this study that hemoglobin levels were positively correlated with development. But what about environmental factors? So these were things that were associated with lower cognitive function in kids, specifically with sickle cell disease. So socioeconomic status, parental social environmental stress, parental financial strain, maternal depression, parental education, and home environment. I'm sure not surprising to a lot of you. All right, so moving on a little bit to cerebrovascular injury and mental health. How are they related? So most of the work and research is done by our psychology colleagues. There's really not, it's starting to grow a little bit, but there's really not a large body of evidence looking at mental health outcomes in sickle cell disease. But, we know that at least as hematologists and especially the pediatricians, were really the first line in picking a lot of these mental health issues up. And if we don't pick it up, then the patients are never really going to get the help that they need. So this is, I just want to talk about the idea of what's called post-stroke depression. And this is something that is a well-known concept in adult stroke literature. So this isn't necessarily related to sickle cell, but just in the adult stroke literature. We know that adults who experience a stroke develop depression at much higher rates. And we know that they have worse functional outcomes and higher mortality. So just in thinking about how that relates to our patients who have really high risk of stroke. So depression and sickle cell disease, we know that the prevalence in some studies is up to 46%, very high. Children with sickle cell disease and depression have higher healthcare utilization, higher overall costs, obviously, more frequent complications, more frequent pain. Patients who have had a stroke, it has been shown to have higher rates of depression. How related, it's really unknown right now if silent cerebral infarcts affect mental health. This is just looking at behavioral issues. So in children who have sickle cell disease and chronic pain, they have higher levels of oppositional defiance disorder and higher levels of aggression. These are parent reported. So, not necessarily related to silent infarcts and cerebral injury, but more so related to the fact that just more part of the chronic pain that our patients experience. But again, I think these all kind of go together. A lot of our patients have neurocognitive deficits. They also have a lot of mental health issues, and they also have higher behavioral issues. I think it would be remiss to ignore the impact of racism on mental health in our sickle cell patients. So sickle cell disease primarily affects individuals of African descent, right? And as a result, patients with sickle cell disease face additional race-related stressors, and like the compounded impact, I think, of structural racism coupled with chronic illness. So I think our patients experience racism to a different degree. And I think that in addition to the pain burden that they already have, leads to a lower quality of life. Black children ages 5 to 17, they've shown in one of the studies that I cited, were less likely to have received any mental health treatment in comparison to white and Latino children in the United States. And those are patients that we're endorsing need. So these findings, like I said, suggest that our Black patients with sickle cell disease are really highly vulnerable to disparities in mental health treatments that I think can contribute to poor mental health outcomes. All right, so now that we know the issues, what can we potentially do about it? So cognitive deficits occur in children with sickle cell disease and CNS injury, and depression occurs at higher rates. So what can we do about it? I think the biggest things are really to screen and intervene when you can. So this was just a quote from an op-ed that Allison King had put out. She's a researcher, does a lot of, she's a sickle cell doctor who does a lot of research on neurocognitive deficits. And she said that, knowing that a child with hemoglobin SS has a pretest probability of 25 to 50% for developmental delay and a 40% chance of having a silent stroke that we know is associated with a drop of 5 IQ points and a 15 to 28% chance of failing a grade. It really seems unimaginable that a pediatrician or hematologist wouldn't advocate for their own child with sickle cell disease to be thoroughly screened, treated, and supported. So the NHLBI guidelines, the National Heart, Lung, and Blood Institutes, came out with an expert panel report in 2014, which is where a lot of our guidelines have kind of stemmed from. So this is that's the most updated, the updated report that we have. But despite studies documenting the effect of depression on sickle cell related outcomes, the guidelines do not address mental health screening. And I think even more importantly, despite over 20 years of studies documenting abnormal cognitive function, again, the guidelines do not address developmental or cognitive screening. So in 2020, the American Society of Hematology, I think, tried to rectify that a little bit, and they came up with guidelines for sickle cell disease related to the prevention, diagnosis, and treatment of cerebral vascular disease in children and adults. And 3 of the questions that they addressed within the guidelines were related to neurocognitive impairment. So the first one, I'll go through them too, but the first one was, should clinicians perform or refer for screening for developmental delay and cognitive impairment? The second question was, should cognitive rehabilitation therapy be used for children and adults with sickle cell? And should screening with MRI for silent cerebral infarcts be used in children or adults with sickle cell anemia? All right, so the first one. So, should clinicians perform or refer for screening for developmental delay and cognitive impairments? What they said was that the panel recommends that clinicians supervising care of children with sickle cell disease conduct surveillance using what's called simplified signaling questions. And if the child, for children with sickle cell disease who have abnormal surveillance, the guideline panel obviously recommends referral for more formal screening. And these signaling questions were adapted from the Bright Futures guidelines for health supervision of infants, children, and adolescents. I'm sure a lot of the pediatricians on the call are obviously familiar with the Bright Futures guidelines. So I'm going to go through just a few of the signaling questions, just to kind of give an example of what they recommend. So for any age child that walks in, the parent-directed questions that you can ask are, do you or any of your children's caregivers have any specific concerns about your child's development, learning, or behavior? I know for us as hematologists, and I'm sure the pediatricians as well, right? You're just really limited on the amount of time you have. So sometimes this is the only question I think that ends up coming out, but I think it's a good place to start to see if the family has any concerns. But these are more directed questions that they talk about. And again, I think the pediatricians are much more comfortable with these questions. I oftentimes feel that as a hematologist, I've kind of forgotten what the correct answer is to a lot of these things. So I think it's hard sometimes to pick up whether or not there is developmental delays in these younger children. So, questions like, does your child wave bye-bye at less than 1? How many body parts does your child point to? How many words does your child say? 2 to 3 years, is your child putting words together? Etc. So again, these are, I think, questions that pediatricians are more accustomed and do ask. For middle childhood, so 7 to 8-year-olds, how's your child doing in school? Are they enjoying school? I think that touches both on cognitive deficits and mental health outcomes. Have they had a lot of absences? We know that our children have a lot of absences. Mainly because of all of the medical appointments that we ask them to go to. So a lot of that is kind of induced by us. But it's always good to ask too, do they receive any special educational services, IEPs, 504s, which we hope that all of our patients get. And I'll talk about that a little bit, or any other special services. And then for adolescents, how are you doing in school? How are your grades? Do you get any therapies in school or extra help? Obviously, adolescents are not the best at answering these questions. So questions that I tend to ask are, what grades do you get? Have you ever needed to repeat a grade? And have you ever needed to complete summer school? I feel like that, sometimes does a better job of asking how they're doing because they tend to think they're doing great. All right, so some important takeaways from this. Screening does improve detection. However, these methods really lack sensitivity, and I think clinical judgment is really important here. And I think in the end, future research is really required to determine the best ways to screen the patients in our specific populations of kids with sickle cell. The next question that they talked about was, should cognitive rehabilitation therapy be used for children with sickle cell disease? And they do, in this question, they said that they recommended that a developmental cognitive medical evaluation to diagnose any related disorders and to identify modifiable risk factors for developmental delays or cognitive impairments be undertaken. So what does that really mean? So one of the things that we do, or we often do, is that if we find a child does screen positive for any type of developmental delay or any school difficulties, sometimes even if they're having things not so much aggression, but if we think it's related, do you think the aggression is related to any type of cognitive deficits, then we'll refer for this neuropsychological testing. I don't know if anybody on the call has ever used the group here at Montefiore, but they really are wonderful, and their assessments are really, really thorough, and I think really, really helpful for our patients and their families. A lot of times the parents, I think, are very thankful that they ended up undergoing the testing, even though it does take a couple of days to complete. So if you're in the Monty system, this is the way that you can order it. It's just an ambulatory referral to a neuropsychology assessment service. And then you can provide the family with a phone number to help set up appointment. They're very busy. And if that doesn't work, then always sending an email to the team. They really are very responsive. And what's nice about sickle cell disease in terms of getting the neuropsych testing done, it's almost always, I would say, always covered by insurance, because sickle cell disease, we know that there's a medical reason as to why these patients are likely going to have neurocognitive deficits, and therefore the insurance company will cover it, because this can rack up thousands of dollars if it's done outside of insurance. So this is just an example of what the neuropsych recommendations will look like. You can see in A, it says like classroom settings. It'll tell you, it'll give suggestions for what type of placement she should be in, what type of setting she should be in, whether or not she should be pulled out. And you can see that in the patient's neuropsych testing that I grabbed this from, she already had a lot of support systems in place at the school. And after she got this neuropsych testing, they really still had a breadth of additional supports that they thought that could be helpful for her. So talks about seating, talks about remediation, talks about group counseling. So they really do a lot of more, they kind of try to include mental health things as well. So in general, I think neuropsych testing, we know academic deficits increase with age, and neuropsych evaluations really provide families and teachers with this diagnostic clarity and evidence-based recommendations to address these needs. This is another case example that we had. So it's a 10-year-old female. She had hemoglobin SS, and the mom had reported poor school performance and memory issues at home. First we said, okay, is this related to her sickle cell disease? She got an MRI, it was normal. She had neuropsych testing, and it really showed global cognitive deficits. They had recommendations for an IEP. We tried starting her on chronic transfusions in 2020 to really say, if this really is for her sickle cell disease, maybe we can try to prevent the sickle cell from contributing to it. However, in 2021, she had another neuropsych testing, and her development had really stagnated, and her full-scale IQ was 62. And the mom always kept saying, her other siblings have sickle cell disease and they're both doing well in school. It just felt like she was different. So recently, we have sent out additional referrals to neurology and genetics. She's getting involved with OPWDD, having her evaluated by behavior and development. Because I do think it's important, I know I'm talking a lot about how sickle cell disease can affect cognitive functioning, but I do think it's important to say to yourself, right, it doesn't always have to be just the sickle cell disease, and we really should evaluate the patients who don't always fit the mold. So this was the third recommendation. So given the high prevalence of silent cerebral infarcts in children with hemoglobin SS or hemoglobin S beta 0, those are the more severe types of sickle cell disease, which is why those two are lumped together. And their association with cognitive impairment, poor school performance, and future cerebral infarcts, the ASH guidelines actually recommended a one-time MRI screening to detect these silent infarcts in early school-age children, when an MRI can commonly be performed without sedation. We know that sedation increases complications in kids with sickle cell disease. So although we want the information to know, which of our children do have these silent infarcts, we don't want to put them at further complications from the sedation. So once a child is able to undergo an MRI without sedation, we often offer this to the families as a way to say, okay, your child does have a silent infarct, perhaps we should send you for neuropsych testing for further evaluation. On patients who do seem like they have a decline, you can always talk to families about whether or not you wanted to either change disease modifying therapies or escalate them. So take home points from this, we as hematologists really need your help, and guidelines are really just no substitute for clinical judgments. All right, so talking about a little bit about interventions. So these are all of the factors that can go into cognitive deficits and depression. And this is just, in general, right, in any child. So things like stress, adverse childhood experiences, toxic stress, we know, chronic illness in general, whether or not that's asthma, diabetes, sickle cell disease, having frequent admissions to the hospital because they're out of school all the time, genetics, so family history of either cognitive deficits or mental illness. Then you have the protective factors, so the family support, coping skills, the child's academic achievement. And then you have disease-related factors, so things like stroke and silent infarcts that I was talking about. All of these things go into that. However, as a hematologist, right, I am best equipped, I think, to deal with the disease-related factors. So that's what I'm going to talk about a little bit in terms of interventions. So modifiable risk factors that we can address. So earlier I had talked about how high hemoglobin S%, right, and low hemoglobin levels can lead to silent infarcts. So what are ways that we can modify those things? So hydroxyurea is obviously the number one medication that we try to start all of our patients on, and we try and start them on it at 9 months old now. One of the trials, the Twitch trial, which was looking at whether or not hydroxyurea can be used to prevent stroke in patients who have abnormal TCDs. But when they went back and reevaluated the data, they looked to see patients who had taken hydroxyurea, what was the incidence and progression of silent cerebral infarcts. And what it showed was that there was no progression of silent infarcts in the patients who had taken hydroxyurea. So that was reassuring. And then patients who have a chronic transfusion. So the SIT trial was a multi-centered randomized trial looking at whether or not chronic transfusions either decrease the incidence or decrease the progression of silent infarcts. And again, it did demonstrate that transfusion therapy reduces the incidence of silent infarcts. However, the number needed to treat was 13 patients over a period of, I'm forgetting the exact number, I want to say more than 5 years. So, the pros and cons of whether or not it is worth starting chronic transfusions for such a high number needed to treat is kind of a decision that you can make with families. But oftentimes I would say we do not often start chronic transfusions. Further things about hydroxyurea. So these are a couple of studies that came out over the past couple of years. And the first one is that earlier initiation of hydroxyurea is associated with higher scores on neurocognitive measures, including IQ. And then on the bottom, the study looked at, or it showed that longer duration of hydroxyurea exposure was associated with higher scores on neurocognitive measures. I've actually been really surprised at how interested both families and adolescents especially are with this information. I think it has really helped reinforce the importance of hydroxyurea compliance, actually. This study, I think, is very cool. This was looking at transfusions and whether or not it improved executive functioning. So what they did was they had patients take a neurocognitive test and then a month later take it again. What you can see in the controls is that patients who took the test and then took it a month later, they did slightly better the second time. The green is the controls, right? So they did slightly better, which is to be expected. You see in the test once, you take it again, you're going to do a little bit better. All right, the second group, this is patients who were taking hydroxyurea, the blue. And what they showed was that same thing. When the patients took the test, they took it a month later, they did a little bit better, to be expected. Okay, so the last one, they timed the transfusions. I thought very smart. What they did was that the first test that the patients took was right after they received a blood transfusion. And then they did it a month later, right before they were getting a blood transfusion. And what they showed was that patients did a lot better right after they had received the blood transfusion, which was the opposite, right? They should have done better. And in fact, they actually did worse, which really goes to show the benefit of the blood transfusion, how it can acutely actually change patients' executive functioning. But what is the downside of transfusions, right? Because they sound so great. Why don't we start every patient on transfusions? It's expensive. It's time consuming. Patients have to come once a month and sit here for, a good portion of the day getting the transfusion. You can get iron overload, which is associated with its own complications, especially as patients get older. And alloimmunization, which is a big issue with our kids with sickle cell disease. So really, besides disease modifying drugs and chronic transfusions, there's really no other interventions known to decrease silent cerebral infarcts. So voxelotor is a newer medication that came out in 2019, and it's currently approved for adults and children 4 years of age and older with sickle cell disease. Now, the mechanism is that it reversibly binds oxygen. We know that hemoglobin S polymerizes when oxygen is released. So by holding onto oxygen a little bit tighter, it prevents hemoglobin S polymerization. The HOPE trial was the study that the FDA approval is based on, but the primary outcome measure was really looking to see if the medication improved anemia. So they were looking for a 1 gram increase in hemoglobin, and the medication did that wonderfully. So you can see on the right, so the red is the placebo. Patient's hemoglobin did not change really at all from baseline. The next line is the lighter blue. That's voxelotor, the lower dose, the 900 milligrams. It did show an increase or a change in hemoglobin, and then the higher dose of 1500 milligrams, which is the actual prescribed dose that we give now, had an even better increase. So we know that this medication improves anemia, right? And we know that anemia leads to higher rates of silent infarcts, and thus likely higher rates of cognitive deficits. So will voxelotor potentially improve neurocognitive functioning? The problem is that we just don't know, right? It hasn't been studied yet. So it doesn't improve clinical outcomes. I think a concern a lot of people have is that voxelotor, the way it works, right, is that it's holding onto oxygen. So is the oxygen delivery to tissues impaired because the red blood cell is holding a little bit harder onto that oxygen? And whether or not, is this going to improve neurocognitive outcomes and improve cerebral blood flow or not? So we actually have a trial open here at CHAM investigating the effect of voxelotor, specifically looking at neurocognitive and cerebral blood flow. Okay, so just gonna talk a little bit about school interventions, which the general pediatricians probably know a lot better than us as hematologists, but this is just specific to kids with sickle cell disease. So obviously participation in school is highly recommended. We obviously feel that the social interaction and the educational experience in school is really important, which is something that even during COVID, we really tried to reinforce with families, that we thought it was important that they actually went to school. So these are some of the special accommodations that we list as part of patients' 504 plans. So some examples are, providing time to rest, access to water bottle at all times. Patients who get dehydrated have higher rates of pain crises. Liberal use of bathroom privileges, because our patients have difficulty concentrating their urine. As a result of that, they make a lot of urine. They have to go to the bathroom more frequently. Same reasons why they have enuresis. Preferential seating is important. Not sitting next to an air conditioner, next to an open cold window. Having access to pain medications, right? Because if they're coming out of class because they're having pain and not able to access any pain medication, then there's no way that they're going to go back to class. So that's important. We do think participation in physical activities is very important as well. However, we always say to tolerance, meaning that we don't want the patients running to exhaustion, because that can also precipitate crises. And then, our patients are absent a lot. We really ask a lot of them. Some of our patients are seen once a month. Some of our patients are seen every 3 months. In addition to that, they can have admissions where they're there for weeks at a time, multiple times a year. So all of these things really can contribute, obviously, to patients getting behind on their work. So we really try to reinforce with the schools that they can send home their class and homework assignments when the child is absent, and really support them, through those absentees. And then mental health interventions. So some of the things that we do sometimes is ask schools to provide check-ins. So guidance counselors can meet with the patients. Obviously, sometimes some of the schools have school-based therapists. Cognitive behavioral therapy is really important. So they can address chronic pain, medication compliance, medical trauma, depression, anxiety. Karen Rogers is the psychologist that is part of our sickle cell team, and she's really wonderful. We really try to refer to her as frequently as we can. All right, so just in summary, patients with sickle cell disease suffer cerebrovascular injury, including strokes and silent infarcts. CNS injury is associated with neurocognitive deficits and depression. And we know that cognitive deficits are associated with worse outcomes related to school performance, transition, and employment. And surveillance screening is really critical to pick up children who need further evaluation. So formal testing can help get access to school-based interventions. So things like those neuropsychological testing, but also disease modifying and novel therapies can improve outcomes. I didn't mention this, but gene therapy is here, and bone marrow transplants are both curative therapies for sickle cell disease. There's not a lot out there on neurocognitive deficits, but in the small studies that have been done, they have shown that these curative therapies don't necessarily improve neurocognitive functioning, but they do, it does remain stable, the neurocognitive functioning, which, as we've seen previously, the full scale IQ can continue to drop into adulthood. So curative therapies really can be a way to potentially address some of the neurocognitive issues that we see in our patients. So there is hope. So does anybody have any questions? This was part of our walk with the Sickle Cell Advocacy Network, which is always great. More advocacy. Happy to answer any questions.
Does anyone have any questions for Dr. Strumph? I know it's been a long day, but she's definitely well prepared. Thank you, Dr. Strumph, for the amazing presentation.
Well, I was going to type it, but I guess can you elaborate specific? If I have children, my children with sickle cell disease or some variants, SC or whatever, neuropsychological testing, the hospitals, where am I sending these kids to? What specifically am I supposed to be asking for or referring to?
So there are other private ones that you can go to, but if
I'm
you're
in New Jersey, I'm not by you.
Yeah, I see. I would have to look. So there are, potentially I'd have to look.
Would I talk to the school? Would I talk to the hospital?
Yeah, good question. So within the school, if you have any patient, obviously we always say have them evaluated for an IEP if they have any issues, because the DOE obviously is mandated to actually provide the neuropsychological testing. So sometimes the schools will provide that testing and we don't have to kind of go past that. But if we are ever having difficulty, that's when we oftentimes just send our patients to the neuropsych team that we have here. But the schools themselves should provide the neuropsychological testing. So that is definitely the easiest, and I think the first place to go, and they're mandated by the state to do it, especially if the parent and especially if the pediatrician.
For toddlers, would early intervention be a good place to go?
Yeah, for sure. Early intervention. I think the problem sometimes is that a lot of these things are subtle. But they oftentimes don't meet criteria, but we have a bunch of our patients who have successfully gotten services, but I oftentimes find that they're missed until school age or until things are more severe.
I can imagine the problems don't come out and bite you, so you do have to look. Thank you very much.
Exactly.
Very helpful.
Thanks.
We also have a question, it looks like from Maureen LaCursey. Hopefully I didn't mess that up. She said, thank you. Your presentation was excellent. Does your center accept outside hospital neurocognitive eval referrals?
Yes, I believe so. I had asked this. I didn't exactly ask outside hospitals. I kind of had asked for the Montefiore system, but I'm almost positive. This is the phone number that I listed right here for our neuropsych team. They really are wonderful, and I do believe that they do accept outside evals. They currently have they're only really accepting patients who have medical reasons for having neuropsych testing, but they're going to be opening up a new program in the fall as well to take referrals for patients who do not actually qualify for insurance coverage. So it will be, pricey, but at least for patients with sickle cell disease, and actually all of our cancer patients as well, are covered. The insurance will almost always cover it. Yeah.